Advanced Practice Without the Title: The Reality of the FCP Role, written by Matt Wedderburn. Over the past decade, few developments have reshaped UK musculoskeletal (MSK) care as profoundly as the rise of first contact practitioners (FCPs) in primary care. What began as a pragmatic response to workforce pressure has quietly evolved into something far more significant: advanced level clinical decision making at the very forefront of the system. In many ways, FCPs have changed the front door of the NHS. Patients now access specialist MSK expertise earlier. GPs are better supported. Pathways move faster. Risk is managed closer to the point of presentation. When the model works well, the whole system works smarter. But as the FCP role has expanded, it has become increasingly clear that the expectations placed on many FCPs now look very much like those of advanced practitioners, even though formally the role is rarely defined that way. For me, that creates a tension within the profession. Because the future of MSK care will not be shaped simply by how many FCPs we employ, but by how well we develop, support and lead the clinicians working at the front line of primary care and how well the rest of the system keeps pace with what that front line now requires. From workforce solution to advanced clinical reality. The FCP model was born out of necessity. General practice was under intense pressure. MSK presentations were consuming huge clinical capacity. Waiting lists were growing. Patients were often being referred into pathways that felt slow, fragmented, and overly medicalised. Putting experienced MSK clinicians at the first point of contact made sense, and in many places it has worked brilliantly. Today, FCPs are routinely assessing undifferentiated presentations, identifying serious pathology early, making referral decisions, managing clinical uncertainty in real time, shaping patient beliefs at the very start of their journey, influencing practice-wide MSK decision-making. This is not just triage or filtering demand. This is advanced level practice in one of the most pressured environments in the NHS. MSK in primary care has become a setting where judgment matters as much as skill, where pattern recognition, risk stratification and professional confidence are tested daily, where the first conversation often determines the entire trajectory of someone's care. And yet, despite this, we still tend to talk about FCPs as if they are primarily a service solution rather than a professional group operating at or rapidly moving towards advanced practice. That gap between what the role is called and what the role actually requires should not be ignored. What's working well? Across the UK, there are outstanding examples of FCP-led MSK services where advanced level practice is properly supported in primary care. Three things consistently stand out. 1. Right expertise, right time. When skilled MSK clinicians see patients first, the impact is immediate. We see fewer unnecessary scans, more appropriate referrals, earlier reassurance, and high levels of patient satisfaction. Having specialist MSK expertise at the front door reshapes what good MSK care looks like. 2. Stability in the grey zones. Primary care is full of grey zones. MSK presentations are rarely neat, pain is complex, fear is common. Red flag pathologies are rare, but very much there. What experienced clinicians bring here is not certainty, but calm judgment. Confidence that comes from experience, pattern recognition, and knowing when not to act. That confidence reduces defensive referrals, unnecessary imaging, clinician anxiety, and patient fear. In this way, advanced MSK practice does more than assess and manage conditions. It helps to stabilise the system. 3. FCPs as translators of MSK thinking. One of the most underestimated contributions of FCPs in their educational influence. Every day, they reframe beliefs and myths, they support MDT colleagues with MSK reasoning, and they influence how practice is triage. They translate specialist MSK knowledge across primary care, and that influence reaches far beyond the clinic room. The tension we rarely name. Here is the issue we do not talk about openly enough. FCPs are not formally classed as advanced practitioners, yet many are expected to work at advanced level. And that matters. Because the responsibilities placed on FCPs increasingly include holding undifferentiated clinical risk, making decisions with downstream consequences, acting as senior MSK decision makers within practices, influencing referral behaviours and shaping MSK pathways. These are not entry-level expectations. They are hallmarks of advanced practice. And yet in many parts of the system, FCP roles are still viewed as sitting somewhere between senior clinician and advanced practitioner without the clarity, structure, or investment that true advanced practice demands. The result is predictable. Some clinicians grow and excel through experience, self-directed learning, mentorship, and/or higher education. Others are placed into roles that quietly outpace their readiness. And that leads to another uncomfortable truth. Quality varies. A lot. Across the UK, the quality of FCP practice varies significantly. There are FCPs working at an exceptional level, clinically confident, comfortable with risk, and deeply influential within their practices. And there are others, committed and capable clinicians, who have been placed into FCP roles before they were truly ready for the responsibility the role now carries. This is not a criticism of individuals, it is a system design problem. The rapid growth of FCP services was driven by urgency. Access had to improve quickly. Roles expanded at pace. In many areas, this meant accelerated transitions, variable training standards, inconsistent supervision, and very different interpretations of what FCP ready actually means. The consequence is predictable: a wide spectrum of practice under a single job title. At one end, clinicians confidently manage complexity and shape MSK pathways. At the other, clinicians are still consolidating core reasoning while balancing advanced level risk. Both are called FCPs, but they are not working at the same level of practice, and the system often behaves as if they are. Don't get me wrong, variation exists in every profession, but in primary care its impact is amplified. When FCP practice is done well, it reduces harm, cost, and fear. When it's done prematurely, it increases all three. But there is another layer to this that we do not talk about enough. Even when the FCP decision is clinically sound, the rest of the system does not always keep up. The rest of the MSK pathway is not up to speed. Large parts of the MSK system have not evolved at the same rate as FCP provision. Across the UK, outpatient physiotherapy services vary enormously in quality, resource, and capacity. In many settings, clinicians are working exceptionally hard within significant constraints. They are delivering care in overstretched services, under intense time pressure, and with limited access to facilities or follow-up. The issue is the system they are working within. In some areas, patients are seen quickly. They have access to proper gym equipment. They receive structured rehabilitation programs. They are supported to progress, not just given advice and discharged. In others, waiting lists are long. Appointments are brief. Resources are minimal. Patients report being handed a sheet of paper and told to get on with it. And then they come back to primary care saying they have failed physiotherapy. They say the exercises did not work. They say nothing changed. They ask, what now? They are often labelled as non-responders, but frequently what has really failed is not physiotherapy itself, it's the quality, intensity and individualisation of the rehabilitation they were given. This creates an unhelpful dynamic. The FCP makes a reasonable physiotherapy referral, the patient waits months, they receive minimal intervention, they return to primary care saying physio has not worked, and now the pressure to escalate, request imaging, inject or refer increases. Not because the conditioner demands it, but because the rehabilitation pathway was not fit for purpose. This puts FCPs in an impossible position. They are working in a system where downstream services vary widely in quality, waiting lists undermine every intervention, rehabilitation standards are inconsistent, and patient expectations are shaped by poor prior experiences. That means FCPs are not just making clinical decisions, they are compensating for system weaknesses. They are trying to hold a line on conservative care in a system that does not always deliver conservative care properly. That is not a small thing. It requires judgment, resilience, and leadership. Advanced level practice. What needs to change next? The uncomfortable reality is this. We have built advanced responsibilities at the front door, but not consistently built advanced pathways behind it. And we have built advanced expectations of FCPs without consistently building advanced support around them. That is not solved by telling FCPs to complete a postgraduate course alone. It is solved by designing better systems and providing appropriate ongoing support and education. That means clearer national expectations of what FCP ready actually means, honest recognition that many FCP roles are in practice advanced practice roles, protected time for development rather than pure service delivery, formal mentorship and supervision as standard, more consistent standards for MSK rehabilitation downstream, better communication between primary care, physiotherapy services, and interface clinics. Advanced practice should be earned through genuine development, not assumed through appointment or credentials alone. And advanced care should be delivered through proper systems, not heroic individual effort. A quiet signal of what's coming next. There is a growing recognition that advanced MSK practice development needs regular support and learning opportunities, exposure to complex cases and advanced clinical reasoning, support with managing uncertainty, leadership development grounded in real-world practice. Not just isolated training days, but ongoing programs, regular CPD opportunities and resources and communities. Spaces designed not simply to update skills, but to shape professional identity, leadership and influence. Something is beginning to form in that space. Work is underway to create a platform specifically designed to support clinicians operating at or working towards advanced level MSK practice. A platform that brings together monthly webinars, a substantial on-demand content library, courses, events, and community based on the realities of advanced practice. This work is being led by yours truly, Matt Wedderburn, not as someone standing outside the profession, but as a clinician working within it, facing the same uncertainty, responsibility, and complexity as others in this role. The intention is simple: to create the kind of space that many advanced practitioners wish had existed earlier in their careers, and one that remains relevant as practice continues to evolve. That work is taking shape as Physio Matters Advanced Practice, or PMAP. Watch this space.